Hello everyone. Today we are going to discuss robotic assisted kidney transplant. We will discuss all the steps one by one. So first we are trying to give an incision for placing the Alexis lab system. This incision is horizontal incision around 8 cm in length, and this is little bit on the left side from the midline. We want to avoid right side because that will be the area where all the robotic ports will be going. We are dissecting the rectus sheath from the rectus muscle, and then we retract the muscles and will go in the pre-peritoneal space. So this is the pre-peritoneal space. Retractors are holding the muscles apart and we are picking the peritoneum. So we have caught hold of the peritoneum by 2 artery forceps, and we are trying to give incision in the peritoneum. After we have cut the peritoneum, we will put our finger inside and we'll see there is no peritoneal adhesion with the bowel, and we are again holding one of the lip of the peritoneum and putting our finger inside just to make sure that there is no adhesion from the peritoneum. This is the Alexis port system. We have folded the lower ring, which is the green ring, and we are placing it inside the peritoneal cavity from the same incision which we have made. And after this is inside, we will untwist the plastic so that the passage is clear, and then we are going to fold the white ring on the plastic itself so that it fits snugly with the incision that we have given. So this is the lid or cap of the port system that will place over it so that air is sealed, and when we create a pneumoperitoneum, air will not be leaking. There is a central hole inside it from which we will place the robotic port, and we can place camera also. So that will be helpful in creating the pneumoperitoneum, and we place rest of the port under direct vision of the camera. This is the standard 8 mm Da Vinci robotic port. This is the marking of the ports. So normally we are placing 4 ports for any other pelvic surgery. This is the same pattern. The only difference is this is not exactly horizontal line. The line is little bit tilted towards the right iliac fossa. On the right hand side, we will take monopolar curved scissor. On the left side of the camera, we take the fenestrated bipolar, and the leftmost would be for retraction, and we place prograsp in that. On the right side, there is an additional 12 mm port placed from which we place the assistant instruments like suction and clips and those things. We are giving a parallel incision on the peritoneum over the iliac vessels. Prograsp is retracting this rectum on the left side so that right side is clear, and we are extending the incision cranially just parallel to the external iliac vessels. So by this we are going to expose the external iliac artery and vein. These are thin areolar tissue. Sometimes you can get some enlarged lymph nodes which might be inflammatory. So those nodes also need to be cleared. Here the incision needs to be very superficial just to cut the peritoneum. If you go deeper, you may find and encounter the ureter, which is the native ureter. So we are just dissecting under the peritoneal incision and trying to expose the artery and vein. Iliac artery is very prominently seen due to its thick wall and pulsation, but vein is very deceptive, and sometimes vein would be coming and just getting injured by your tip of the scissor. Due to pneumoperitoneum effect, vein is mostly collapsed, so this is not that clearly visible until you reach to its surface. Here there are some adhesions around the artery and vein, maybe some previous inflammation, we don't know. You can see the direction of my scissor. I am always trying to keep the tip of the scissor away from the vessels, and we can use the back surface of the monopolar curved scissor, which is the curved one, and that is very atraumatic part of the scissor, from which we can push the artery or vein away from it so that there is a dissection. Here there is dense adhesion between the iliac artery and vein. So we are putting our fenestrated bipolar inside and trying to create a space by pulling both the jaws apart. This is a very safe way of dissecting. It will not injure. Once we have created a small window between the artery and vein, then we are going to increase that space and take a vascular sling. Vascular sling is clipped by a hemlock clip, and then it will help us in retracting the vessel to the desired directions that we want, because we need to dissect the artery and vein 360 degree so that there is no tissue lying between the artery and vein, which will make clipping easier. So we are placing just a hemlock clip on the peritoneal wall so that the rectum and sigmoid colon is lateralized and will not keep coming between the dissection area. Here we are putting the same way fenestrated bipolar inside, and we are dissecting upwards towards the inguinal ring. Just incising the peritoneal incision little bit cranially and caudally. So whatever tissues are lying over the artery and vein that need to be dissected, any extra tissue will create confusion while suturing the graft vessels to the iliac vein and artery, so that there should not be any confusion. So we dissect all the extra adventitious tissue, adipose tissue, or even some lymph nodes away from the vessel wall. So now we will create a flap by giving a perpendicular incision on the previous incision which we have given, which was parallel to the iliac vessel. So we are just giving a perpendicular incision on the peritoneum and extending the incision laterally. This will make a peritoneal flap which will be useful for placing the graft below this. The better you create this flap, the better will be the positioning of the graft, because if the flap is very small, then maybe you will not be able to put the graft there properly and it will always fall back. So just make this flap and leave it there. Once we have done the anastomosis, then we are going to take this flap and medialize it and then fix the kidney there. We are putting the bulldog clamp inside. There are 4 bulldog clamps you can see here. We have tied a silk thread on the back of it so that handling becomes easier. So now the graft has been placed inside. There is a jacket that we have made from the gauze piece, and we have placed crushed ice around the kidney graft. This ice is going to be melt within 10-15 minutes, and then my assistant would be pouring ice cold saline over this graft so that the temperature is always lowered. So we can see the artery and renal artery and vein both have been dissected on bench. The ureteric end of the graft is marked, and ureter has to be placed downward. So we are placing the bulldog clamp on the iliac vein, and this is the iliac vein that we are going to anastomose. So first we are giving an incision on the external iliac vein. Incision has to be matched with the lumen of the renal vein. We are using the spot scissor, which is a very sharp and thin edges, which helps in cutting it very precisely, and we should remove a little part of the wall so that the venotomy is wide open and quite visible for my anastomosis. This is the 6-0 Gotex suture that I am taking. One suture would be used for artery and one for the vein. So from that side we have gone outside inside on the iliac, so inside out on the renal vein. We'll put the surgical knot. Gotex is very thin suture, and when you hold it very tightly you'll feel that it's going to break away, but doesn't break so easily, and there will be some marking of your holding that you can visualize on it. We should try to avoid holding the needle directly and pulling it, because needle tip is very sharp and it can bend. So we should avoid holding the needle tip from the instrument. Now we are coming back from outside to inside of the renal vein, and then we'll go in the external iliac vein from inside to outside in this manner, and again go into the renal vein from outside to in. So the same step has to be repeated now till we reach at the other end of the renal vein. So now we have reached to the other end, and first we have gone inside the iliac vein, came outside, and then we will be going into the renal vein from outside inside, as we have done till now. We have to make sure that we are taking the full intima and there should not be any space getting created there. We are keeping this end little bit loose because we are going to take a knot on this loop which we have created, so that one layer is fixed. So after we have reached at one end, we take the knot in this manner, and the same thread will continue for the anterior layer of the vessel. Again we will take 3 knots or 4 knots. So now we have again come inside the iliac vein, and then again coming out of the renal vein from inside out. Make sure that you pull the thread little bit after taking each bite, so that there is no looseness and all the stitches are equidistant and tight. You have to be very gentle while doing this anastomosis, because you don't want to hold the venous wall with the instrument. Just try to lift it with the needle. Now we have reached to the other end, previous end where we started the anastomosis, and then we are going to lock it with the previous thread. So using a single thread on one side helps us in saving the cost as well as time. Now we have taken another bulldog clamp and placed on the renal vein. We are just trying to find out the renal artery. So here it is. This renal artery has already been spatulated at the inferior end. We have taken off the proximal clamp from the vein and putting it on the external iliac artery proximally. Another clamp from the distal end of the vein will also be removed, and we will place it over the distal end of the external iliac artery. We have to We're very vigilant that we are not catching hold of any other tissue behind the artery, because that will make the grip of the clamp loose and that may cause some bleeding. Just to be further safe, we are placing one more clamp proximal to the first clamp, which is placed on the proximal part of the external iliac artery. Sometimes artery may be very thick and just one clamp may not be sufficient, and you may have some blood trickling from the artery. So no problem in applying another clamp, and just be 100% sure that there is no leakage of blood while you do the arteriotomy. We are just getting an idea about the probable site of arteriotomy where the renal artery will be reaching easily. First, we remove if any adventitial tissues is lying over the vessel wall, and then we are giving an incision with the pot scissor. During all this surgery, my assistant would be intermittently pouring the cold ice saline on the graft. So now we have made a small arteriotomy incision. In a atherosclerosed artery, what happens that when you have given an incision or arteriotomy, you may have not reached inside the lumen, and we may create a space between the intima and adventitia. So that need to be avoided, and we have to make sure that we are inside the lumen. Many a times some small plaque will be popping out. You need to cut it so that the edges are very sharp and there should not be any dissection in between the layers. So this is the arterial punch, long arterial punch which we are using, and we'll make the arteriotomy bigger. So this is one punch that we have fired. These are some intimal tissue or some plaque that is hanging there, and we just want to remove it so that edges should be very sharp and clearly visible for a better anastomosis. So these extra tissues should be removed. In a younger recipient, normally the vessel wall doesn't have these kind of layer because there is very minimal deposits of lipid. But in old age patient, as he is a 65-year-old gentleman, you may find such picture. So now the same Gotex suture we are taking, coming from outside to inside of the external iliac artery, and we take exit from the renal artery from inside out at the lower end of the spatulation. Spatulation of the renal artery is always done on the inferior side so that it fits exactly in a proper anatomical position on the external iliac artery. So we'll put the first 3 knots in a surgeon's knot fashion, tighten it, see, many times people talk about the warm ischemia time is little more in case of robotic, but if you are good at anastomosis, then the surgical time for anastomosis of artery and vein is almost same as your open technique. So normally I take around 30 minutes to 25 minutes for artery and 30 minutes around for vein. This is both in the open surgery as well as in robotic. So now we are coming inside the renal artery from outside in, near the corner, and then we go inside the external iliac artery from outside in on the posterior wall. Try not to hold the edges of the artery because that is definitely going to crush the edges, and that becomes very difficult later on to keep in proper alignment with the anastomosis. Again, renal artery is entered from outside in and external iliac artery is exited from inside out. So whatever way you are doing, that should be constant, and just keep following the same principle till you reach the other end of the arteriotomy. Once posterior layer is done, then at the corner we are going to lock the suture in the same way by leaving a small loop of the suture outside and then tying it with the suture, and continue the same suture for the anterior wall anastomosis as well. Always spatulate the artery very leniently so that there is good anastomosis and kinking and those problems of the anastomosis will be less. So this is the loop that we have left at the end, and we will tie off with the same loop once we come out from the external iliac from inside out. Make sure that the suture is very tight inside. Only a loop should be loose, otherwise you can leave the inside suture loose, then that would be a problem later on. Just checking my anastomosis line. All the sutures are well tight and in position. Then we take 3 knots here. First is surgeons. 3 or 4 knots, whichever we feel like is okay. So now the posterior layer of anastomosis is complete, and we will try to reach to the other end of the artery. So we are again entering from the external iliac artery from outside in and taking exit from the renal artery inside out. These all depend on which is your dominant hand. For a right-handed person, this approach is convenient. If you are left-handed, then you can accordingly modify it. You can come from other way around. It's no issue. Whichever way you do, the most important thing is to keep all the sutures properly tight and equidistant. When we have reached to the end, just before that, we place the ureteric catheter inside, put some hepsaline, flush it, and then we complete the anastomosis. As I said, try to avoid holding the needle just by the end of the tip, because the same needle is being used for the whole anastomosis. So if there is some bending by holding it with your instrument, then it becomes difficult to continue and you have to just change the suture. So now we have almost reached at the end, and we will take another suture just to go past the first suture to overlap it. We are now closing the anastomosis and just locking the suture finally. So this completes the anastomosis. So after we have anastomosed, I'm just cutting the jacket a little bit on both sides of the vessel. In real time, both these anastomosis took around 55 minutes. So now artery is quite visible, and we are going to place a clamp on the renal artery. So we are taking off this one clamp, bulldog clamp, from the proximal iliac artery, and the same can be applied on the graft renal artery. So here we go, and it is clamped. So now we are removing this distal clamp on the iliac artery, so that there is some backflow that is happening from the distal iliac and femoral to the anastomosis site, and we can have an idea if there is some significant leakage from the renal artery anastomosis line. That seems to be okay. There is no significant bleed or leak at present. We have placed some Surgicel just to keep it pressed for 1 minute. Then we review it again. One of the best part of robotic kidney transplant is very minimal blood loss, because there is limited dissection just on the vessels, no muscle cutting. So the chances of bleeding as well as post-operative wound complications are very minimized. So now we are removing the clamp from the renal vein. Here we go. And then next we have removed clamp from the renal artery. So the proximal iliac clamp is the last one to get removed, and now the blood supply to the graft is fully restored. So now we have to remove the kidney jacket. This is the suture that we have placed on the jacket just to close it. So this suture should be loose and very distant, so that you don't have to apply too much of your energy in just removing it. So after we cut that thread, the jacket is wide open. We can see the kidney surface that is well pinked. There is no surface bleeding as such. The little bit oozer are there that will be taken care by our bipolar forceps. So we do hemostasis later on. First we remove this watch piece which is covering the kidney. Be very gentle in removing this jacket. Sometimes it may get entangled with the renal artery or vein, and pulling or applying too much pressure may be very traumatic to the vessel. So be gentle in removing it. This is the ureter. It is lying at the lower end of the graft. It has started forming urine. We will see it in a more precise way after some time, that how the urine is coming from the ureter. Now this gauge piece is removed, and we are going to remove the vascular sling as well. So this is the surface coagulation that we are doing with bipolar forceps. If there is some significant vessel which is on the surface, you can even apply Liga clips, but it is not required usually. This is a bulldog clamp that we are taking out with the applicator, so that it fits easily and comes out like this. Now this flap which we created, that flap would be brought to medially, and we position the kidney under this flap. So we can apply few bulldog clips, hemlock clips, and fix the kidney there. So now kidney is almost positioned there. Ureter is forming urine. We can observe the flow of urine that will be coming here. See. So urine output is quite good. Immediate urine production has started. That all depends how less warm ischemia while harvesting the graft. In this case it was 3-minute warm ischemia time while removing it from the donor, and while anastomosis we took around 55 minutes. So this is the urine output, quite robust. We are going to spatulate the ureter and anastomose to the bladder. So now we are giving a incision on the bladder. First we incise the peritoneal fold and bladder serosa, and then we create a tunnel. The detrusor muscles are divided by monopolar curve scissor, and we can do a little bit blunt dissection with the scissor and with the help of the bipolar. We have to reach till the bladder mucosa. Bladder is already inflated with around 300 ml of normal saline. When you see the bluish hue of the mucosa, then that is the limit of our dissection. We would open the mucosa after taking a stay suture with a 3-0 vicryl on the top of the vesicotomy incision, because after decompressing the bladder wall may fall off, so we are holding it with a traction suture. The mucosa is opened and we have brought the ureter there. Ureter reaching easily, there is no problem. The anastomosis will be done by 4-0 vicryl suture. We always do a stented anastomosis, and we would be placing a double J stent, which is 5 French 5 French 16 centimeter. 5 French is the width and 16 centimeter length. The anastomosis of the ureter with the bladder mucosa has to be mucosa to mucosa. After placing one stitch at the lower end of the vesicotomy, I am placing this stent inside. You can place the stent even after completing your one layer anastomosis, but I feel that for me it's much easier to place the stent and do the rest of the anastomosis, because this makes the vesicotomy incision wide apart and you can easily see the edges of the bladder mucosa, and you keep doing a continuous anastomosis. This I am taking at the end of the other end of the vesicotomy, inside out on the ureter, and then take a knot. The rest of the job becomes easier, and we can come from upward to downward and do a continuous anastomosis. At the end we have taken the full thickness of the bladder at the superior end, but the rest of the bite we are trying to take only the bladder mucosa and whole wall of the ureter. We are not trying to take bladder detrusor muscles, which would be part of the second layer, to buttress it and to create a tunnel. So on one side the anastomosis is completed. We are tying the first thread to the previous one. and then again we are coming from upside down and doing a continuous suturing with 4-0 vicryl. So after we have reached to the other end, we'll join both the thread together. I would always advise that before you embark on your robotic KTP journey, you should do few pyeloplasties, ureteric reimplantations. This will make your suturing practice better, because ultimately robotic KTP is all about doing the suturing. And this is the final picture. The incision was very small. We took subcutaneous bites. So thank you so much, and keep following me and subscribe to the channel. Thank you.